Yeah. Thank you so much, Mats, and thanks to all of you as well. What a great pleasure to be invited to Stockholm and see familiar faces of friends and colleagues. And thank you as well. Every time I come to Stockholm, the hospitality is really overwhelming and wonderful, and very humbling to speak within the Nobel Forum. So thank you, Mats, and thanks to everyone. So I think in this hour, Dr. Theodore and I will touch on some of the deeper scientific and clinical problems that we're working on specifically. So I'll touch on mainly two topics, on advances in three-dimensional imaging and image registration for image-guided interventions. I'm funded mostly by the National Institutes of Health, but also with industry support. So we have research collaborations with Siemens, Medtronic, and Carestream, and also some disclosures here. I want to start by acknowledging, first and foremost, is Dr. Theodore, my co-director for the Carnegie Center for Surgical Innovation, where we do a lot of this research, but then also other faculty in biomedical engineering, Webb Stamen, Wojtek Zbiewski, other surgeon collaborators in neurosurgery and orthopedic surgery, and many postdoctoral fellows and graduate students who have contributed to this work. And always looking for new experts who want to travel abroad and study and learn in a new place. Well, almost 20 years ago, cone beam CT is a technology which you probably know about and started to come onto the scene in medicine in a couple of interesting and very different areas, such as dental imaging and image-guided radiation therapy. And there's a similar principle at work here. It's an X-ray tube and a large area detector that forms a fully volumetric image of the patient from a single rotation around the object. And so without having to shuttle the patient through the scanner, you're able to image an entire volume. That has a lot of applications. And over the last 20 years, we've seen it develop in many different forms in image-guided radiation therapy, image-guided surgery, ear, nose, and throat, or otolaryngology, breast imaging, and most recently, perhaps even musculoskeletal imaging. I want to focus in on one part in particular here within the image-guided surgery space where we can expand that even further. Imaging in the operating room, in many ways, uses all the forms of imaging from diagnostic radiology. And sometimes we just transplant those directly to the operating room. But more often, and perhaps more interestingly from an engineering perspective, we reinvent these technologies in new forms that are specifically well suited to the operating room, including CT scanners, fixed room type C-arms fixed to the ceiling or the floor, and then mobile intraoperative imaging systems like those shown here. But the image quality, if you talk to a surgeon about the image quality on any of those systems in the operating room, they'll tell you quite simply that they're good for imaging bone. And pretty much, I think that they would tell you that it stops there. So the first topic I'm going to talk about is that it doesn't have to stop there. Now, these imaging systems have the capability to provide image quality sufficient for visualization of soft tissues, muscles, fat, tendon, ligament, hemorrhage, and therefore could bring a level of quality in the operating room that could be useful for other kinds of interventions beyond orthopedic, and also provide quality checks or safety checks in the operating room. For example, a hemorrhage or a tool, a device left behind, or something that could be difficult to detect. So how do we do that? How do we get high quality cone beam CT off of such mobile and low-powered systems? Well, there are a lot of technologies that come to bear on this, including the system design. The quality and performance of flat panel detectors is improving, and there are emerging classes of detectors like CMOS that provide lower resolution, higher spatial resolution, or lower noise, higher spatial resolution, and faster frame rates. Also, artifact corrections. All of the artifacts that we know from computed tomography are there in cone beam CT, and some are significantly greater. for example, X-ray scatter. And what I want to touch on most is this emerging role of what I'll refer to as model-based image reconstruction or optimization-based image reconstruction. And this is a class of reconstruction different from filtered back projection, which is how most CT has been done for the last 3 or 4 decades. And it's particularly good in ways that are well suited to the operating room. It can deal with sparse projection data, so just much fewer views. It can work well with lower fidelity detectors compared to the detectors that we have in multi-detector CT. The geometry is flexible for these kinds of reconstructions. You're not limited to a circle, and nor are these C-arms that we're talking about. They're not limited to a circle. And these kinds of algorithms are well suited to incorporating prior information about the patient or about the devices that we know to be in the patient. This is a slide borrowed from Webb Stamen, and he has a really nice virtual library presentation on the AAPM's virtual library. So we can think about these kinds of optimization-based methods in terms of 3 general classes with a lot of overlap. Models that use a forward projection simulation of the imaging system, models that enforce desirable image properties, spatial resolution or noise, and models that employ some kind of statistical description of the underlying image formation process. And some of the ones that you are probably familiar with are here. Maximum likelihood, for example, combining a statistical model of just photons incident on the detector and a forward model, right? A projection process that simulates the transmission of photons through the object, and others. Now, in the last, I guess I would say 6 years or so, many commercially available systems have in fact, all commercially available CT systems have exposed some form of iterative reconstruction methods like the ones shown here, where these are kind of a best guess as to what methods these different algorithms are employing. I'll just start with a little bit of the algorithm for a basic one, which is that uses a statistical model of photon noise, and it's iterative in the following way. So it's called iterative reconstruction because what we're doing is we're making a guess iteratively about what the true object would be, right? So here's our current estimate, and we want to guess what that image must be based on a measurement of its projections. And so we can maximize the likelihood that these projections yielded this data, and we'll iterate on that process until we maximize, in this case, the log likelihood of that data. So that's maximum likelihood. We can penalize that to enforce certain image properties, so-called penalized likelihood. And the kinds of priors that we can enforce here, for example, are in the form of a regularization. There's a weighting term that describes how strongly we want to penalize against, for example, differences in voxel values. So here's a regularization function that's some function of the difference between voxel values. And so we can penalize very large differences, more so than small differences by way of some penalty function, for example, a linear function or quadratic function. So that's just a little bit of an overview of what we'd consider to be a basic penalized likelihood method. It's interesting, I think, to just kind of view how these algorithms form an image. I hope you can see okay in the light. This is a filtered back projection image reconstructing, and you see that's a classic way of just taking the data from the projection and back projecting it through the space of a volume and building an image of the patient. The penalized likelihood method works quite differently. Here you see after one iteration, it has a little bit of a match as to what this object might be. But with further and further iterations, it gets a better and better match to the projection data. But it populates that estimate in quite a different way than the filtered back projection. You saw the low frequency characteristics sort of fill in first, and then finally the finer and finer details, at least in this example. And that should start to give you a little bit of an intuitive feel that these algorithms are more robust against certain effects than filtered back projection. Noise in the projection data will just be cast directly back into the image in a filtered back projection. But in the iterative reconstruction method, just because of how it's actually making that estimate, we could gain some level of robustness. And the benefits to image quality and dose reduction can be fairly significant. Here's an image of a cadaver in the region of the spine and kidney and surrounding fat. The same data reconstructed with filtered back projection and with penalized likelihood. Here an image this is a patient image in the region of the brain, and we're seeing, hopefully you can see a difference in the noise and resolution properties. And just to quantify that, so this is in this kidney image with the spatial resolution matched to about 1 millimeter edge spread width at the edge of the kidney and fat. And you see that the contrast to noise ratio versus the dose, right, for conventional filtered back projection is here. But for the same data, we could reduce the dose by about a factor of 2 and still gain a significant increase in the contrast to noise. And here, this is actually data from Dr. Theodore's operating room, where we do the same using an O-arm. So these algorithms bring a number of tremendous advantages. I only touched on a little bit of that. But they also come with a price, and that's computational load. They're slow. Maybe 5-10 years ago, any one of those images would have taken many hours to reconstruct, if not days. And so there are a few ways to deal with that. Of course, there's GPU and parallel programming. The algorithms that I've described are highly parallelizable, so that's good news. But there are other methods as well, and more intrinsic to the algorithm, and I've listed some of those here. For example, ordered subsets. So this is a way of breaking all that projection data up into a number of subsets, and they reconstruct them all in parallel. And that tends to give you a speed up in proportion to the number of subsets. But there's another one that that if you're interested in this area, or in fact any kind of optimization method, or many kinds of optimization, that I hope you know about, and that's a momentum-based acceleration, or so-called Nesterov acceleration. And it's fairly general and can be applied to optimization-based image reconstruction as well. And I'll show you some of the speed up that you can get with these kinds of combinations, and then also just simplification of the forward projectors that are involved. I won't go into too much detail here, but there are simpler forms of forward projectors that can be give you considerable speed up. So there's a lot of data here, but let's take a look. So a typical reconstruction, for example, right here, of about 500 projections reconstructed to a fairly large volume, might take something like 15,000 seconds, and I can't remember how many hours that is. It's too long. Dr. Theodore is not going to wait for this image in the operating room. But here, for example, through increasing the number of subsets, right, we can get a significant reduction. And then here, with Nesterov, we can see we can get a 10-fold increase, and then another factor of 5 through using simpler forward projectors. And so that's really good news, but it doesn't come for free. These kinds of acceleration methods can introduce instability. And if too many subsets or too much momentum, which is a parameter in the optimization, can lead to some instability. I'm showing that here. So this is the error in the reconstruction as a function of time. And so each one of these curves represents a certain setting, and here we see an algorithm coming down and converging and reducing the error in the estimate, and in a little over a minute, we reach a certain level of accuracy in the image. If we simply turn up the number of subsets, we can get some really poor behavior, and the image just diverges, and it doesn't reach a solution. And so stabilizing these kinds of advanced speed-up methods is really important. And so here's our best effort so far. It involves a modest combination of subsets and momentum and a multi-resolution pyramid where we start reconstructing the image coarsely, and we go finer and finer in scale. So as the iterations are moving, we're actually reconstructing to finer and finer voxels. And so now we're getting that same image in about 20 seconds. So that's a pretty good benchmark, and that's about where you need to be if you're going to reconstruct images like this in the operating room. So these kinds of advances offer the potential for soft tissue visibility and hemorrhage and a potential for intraoperative QA and a check on complications, which could take systems like this to additional roles and increased functionality in the operating room. And this emerging role for model-based image reconstruction is very exciting from a scientific, algorithmic sense because it gets beyond what we would consider to be conventional noise resolution trade-offs. And the advantages, if you look at what I've listed here, these are all things that that are particularly relevant in the operating room, even more so than they are in diagnostic radiology. And of course, the barriers of computation time continue to fall. Those are not durable barriers. So that's good news. But I want to shift focus a little bit and look at the operating room. And I would say here's a snapshot of the minimum amount of information that Dr. Theodore deals with in the OR every day. Here we've got the patient and what I would call the cycle of surgery. The brain, right, the eyes, and the hands. And they're interacting with the patient in some way and patient monitoring. There's some preoperative image data and some information pouring in from the system more generally. The kind of technology that I just described is just one example of technologies that we're pouring into the operating room every year to provide navigation, multimodality imaging, robotics, image registration, video endoscopy, and then all this additional information pouring in from the hospital information system. This is a bit too many things, right? A complexity overload, and can break workflow in a fairly demanding environment. So I want to back up and just look at one really simple example of where technology can help workflow, improve safety, and maybe complicate it under the hood, but is streamlined in its function. And so shown here on the left of the screen is a lateral radiograph of the spine. And this is an image that's taken at the beginning of every spine case, and with the specific purpose of localizing the target. Here you see a needle placed on the surface of the patient with the intent of localizing which target the surgeon is intending to deliver, let's say, a pedicle screw. Even a chest radiologist would be hard-pressed to tell you unequivocally which vertebrae they're looking at. And the reasons are because, well, the images, there are many ambiguous landmarks here. There's no clear, unambiguous landmark here in the mid-thoracic spine. And even though it would be considered a never event to operate at the wrong level, it happens more often than we would like. In fact, about 1 in 3,000 spine surgeries meet with a wrong level event. So the countermeasures to this are counting, right, from an unambiguous landmark like the sacrum or the first cervical vertebrae, counting your way down. That could meet with human error. A separate procedure before the operation under CT guidance to tag a vertebrae with cement. And just a lot of time and a lot of stress to get it right. And surgeons get it right almost every time. But they bend over backwards to get it right. So when we learned just through daily interaction with surgeons that this was even a problem, right, we'd all heard of wrong side surgery, left side, right side errors. But this wrong level surgery has a different root cause. And when we learned about it, we realized a solution. Right, and here are just some more examples. Here you see a patient with a bone cement tag there. Here you see the challenge they're presented with dense instrumentation and poor quality images, and even anatomical variations like a lumbarized sacrum or a 13th thoracic vertebrae. But the solution that we realized is probably clear to you as well. If we have information on this patient preoperatively in their CT, and we simply plan and label the vertebrae of interest. In fact, there are algorithms to do this automatically, that we can relate this information that we know to be true and accurate preoperatively with this image that we're acquiring in the operating room by way of a registration of this 3D information to this 2D information. And there's another iterative optimization under the hood in this that computes a digitally reconstructed radiograph, just a simulated forward projection of that 3D image, compares it in some way to this 2D image. In this case, it's a similarity of gradients, and then iterates and optimizes on that objective function, maximize this gradient strength as a function of as many as 9 degrees of freedom that the X-ray source might have with respect to the patient. And when we've solved that and we think we've found the global maximum, we've solved for the pose, then we can simply transfer these labels through that same pose and superimpose them on the patient. So that's an algorithm we rolled out into 400 studies that we did and measured not only its performance in labeling vertebrae like this, but also its potential improvements to workflow. And it's pretty robust. It's also interesting to note that, to the choice of similarity function that would make one robust against features that are only in one image, right? All this instrumentation is in the radiograph, but not in the CT. And so how to construct a similarity metric that ignores gradients from one image, but counts consistent gradients. So we extended that also to a deformable registration. If you think about it, what I just described is a rigid registration, but by scaling it down to finer and finer scales, we're able to go from a rigid estimate like you see here to one that properly accounts for level by level errors, and then a fairly straightforward extension to preoperative MRI by taking a T2 weighted MR where we've labeled each vertebrae, a region growing algorithm to segment the vertebrae, and then really the same kind of optimization framework to be able to cast those labels forward. So I mentioned earlier that some of the functionality that we're after here is safety and quality checks in the OR. And that's an example of one where it would provide a safety check to help the surgeon localize the vertebrae, or at the end of the case just confirm that the correct levels were treated. But we could do more. We don't have to stop there. We can evaluate just from these images, is this the implant that was intended? Or what were they, really? Maybe we want to feed learning algorithms later to look at variations in outcome based on the implants that are delivered versus surgical outcomes. And is it placed correctly? Well, there's is that screw as intended down the pedicle and into the vertebral body? Or, do we have something like this, a medial breach? And we would certainly want to be able to detect that in the operating room and revise it. The patient could actually do just fine if we were to detect that and reposition that screw like that. Well, there's enough information in the radiographs that are being acquired to perform exactly these kind of quality checks. And I'll show you how. It's actually just what we've just seen with the patient. So here are the radiographs, here's the CT of the patient, and this is what we just looked at, the level check registration of the patient, where the patient's CT is providing the 3D model. But for these screws, we can do the same thing. We can take a 3D model of the screw and do the same kind of 3D to 2D registration to solve for the position of those screws in the radiographs and, more importantly, in the three-dimensional image to be able to detect a breach like that. It looks like this. Here's a typical sort of spinal pedicle screw. If we know exactly its form, right? If we're working with a manufacturer who provides the CAD models and so forth, that we can get a very accurate model of the screw and predict what it looks like from any view. Or we can go with fairly simple parametric models of the screw. In either case, it works pretty well. Here you see I've slowed this optimization down about a factor of 100 to show you how that registration locks in on the position of that screw. We've done other studies that deal with collisions or overlap within the radiographs. And you see here with many screws delivered that we're able to get accurate registrations. And the error in the location of the tip and the angle of the screw. If you know it exactly, this exactly known component model, we get better than a 0.5 millimeter accuracy and better than a 0.5 degree. But even with those parametric models, right, just very simple shape descriptions of the screws, we're still able to get to better than a millimeter accuracy and about 1.5 degrees. So that would enable us to do that kind of a quality check for every screw at the end of the case and give kind of a quality report, a record and verify that the screws are delivered safely in the OR and not discover that afterwards in a postoperative CT. And so I just want to finish with one thing that I think this is particularly good at, and that is in the rapidly emerging area of robotics, where conventionally a robot like this might be tracked with an optical tracking system. And that's good. There's some limitations with optical trackers, but if you think about it, it's an ideal marriage between a robotic assistant and a fluoroscopically guided procedure. And it's that same kind of an algorithm that I've been describing. So we have a patient registration, right? So in this fluoroscopic image, we can register the 3D position of the patient. But here we see the tool held by the robot. And we, through that same sort of known component model, register it, and therefore know its position and guide the robot to an intended location. Here's just a screenshot of our software called Trek. It's really 3D Slicer as a front end, and the Hopkins libraries, which are called the SIST libraries. Those are open source libraries for image-guided surgery. And here you just see the robotic guidance implemented here, where we've got a plan. We're able to orient the robot on the plan as a drill guide assistant to get screws delivered accurately within the spine. And then here are results from a cadaver study. So this is an interesting cadaver study because we purposely put the cadaver through fairly strong deformations. We scan, the preoperative CT, they're laying supine. And in the operating room here, they're laying prone. And in fact, they're not just laying prone, but we've really distended the spine, purposely imparting deformations. And as you see here in these plots, a tracker can be really susceptible to these deformations with upwards of 6 millimeters error in some cases. But because the known component method is able to not only accommodate the deformations, but work locally at the level of individual vertebrae and is really registering to those regardless of what the patient, the deformation is, they're locking on to the patient as they are for real right now in the radiograph. They're able to guide those to an accuracy of 2 to 4 millimeters, even with strong deformation. So the opportunities and challenges associated with advances in 3D imaging and image registration in the OR, I've discussed the potential for increasing the image quality and reducing the dose by way of optimization-based reconstruction methods, I think is a very promising area. The idea of using the imaging systems beyond conventional navigation, right, to use fluoroscopy and so forth to provide localization guidance and operating room quality assurance, like ORCA. Right? Something that's very well developed in radiation therapy and something I think we have the opportunity to see more of in surgery is intraoperative QA. If you think about it also, these kinds of image registration methods provide a means of automatically annotating data, identifying which vertebrae these are, finding these components, right, seeing which of these screws, and automatically annotating a lot of data automatically is essential to doing big data analytics. It also underlies methods for automatic planning, but something I'm really interested in is using these registration methods on big data sets to understand how variations in the surgical product relate to variations in the surgical outcome. I sort of painted that picture of technology paralysis, where a conglomeration of technologies in the operating room can really impede the workflow. And there's a real challenge before us as engineers to bury complexity in the same way as your phone, right? Your phone is this exquisite computer and machine learning algorithm, and you don't know how it works. I don't know how it works, right? The complexity of this device is buried, and that's okay. It can be complex under the hood. It has to be streamlined on the surface, and that's the kind of technologies that we need to be thinking about for the operating room. Right. And with that, I want to thank you very much for your attention.